Thanks for coming, first of all, and letting me steal some time out of your day. Today we are talking about liver disease and protein needs. So based off of, like, I was asking some of you what you wanted to do, what you wanted to learn about, that was kind of what we were talking about. So, a review of the liver. As I think about everything the liver does, it's actually really amazing. Synthesizing all the blood proteins, albumin, prealbumin, transferrin, prothrombin, secretes bile, digestion, absorption of lipids, degradation and excretion of ammonia, all the different drugs, and it regulates all the different nutrients between fast and fed state. So it's really no surprise or no wonder that when someone has liver disease, they really are going to have significant malnutrition. Um, so then we talk about, okay, well, nutrition assessment, kind of problematic, especially with liver patients, because usual indicators of nutritional status are already altered directly due to the pathophysiology of the disease itself, so it creates a challenge. So here we are, we have to provide these needs, but we don't really know if what we're using, our lab values and everything else is the best indicators, but we kind of got to go with what we got. So, of course, there's the standard manifestation of the protein calorie malnutrition and the wasting and all that kind of stuff. So, in general, what hospitals are doing, or mainstay hospitals, um, what has been happening in the past is that the goal is just to provide adequate nutrition, adequate calories, adequate protein, but without um, giving too much because they're worried that it's going to induce encephalopathy. So if someone already has encephalopathy, they usually reduce protein, or if they're worried about it, then they want to keep it at a low protein diet. Um, so protein restriction is classic of mainstay treatment in hospitals. Um, but we're going to look at some studies, and we're going to talk about, is that appropriate? What do we think? What does the ADA say? And we're going to do that within our allotted time limit, don't you worry. Just kidding. So the first study that I looked at was published in 2004, and it's actually the best one that is out there right now for true clinical studies, the randomized controlled clinical studies trying to do the best that they can for all the factors. Research is hard, especially in hospitals. There's so many other things that happen. So this is it, fabulous one. Normal protein diet for episodic and hepatic encephalopathy, results of a randomized study. So the brief points of this are, this was one of the articles that got published that set the whole ball into motion about what are the protein needs. They studied, their sample size was 30 people. So that doesn't seem like a lot, but based on all the criteria that they had to go through, it was really extensive, so they got their group really detailed. They split them into two categories, low protein and normal protein. So they fed these patients through an NG tube for 14 days, and they controlled calories. It was 30 calories per kilogram. And then the low protein diet got no protein for 3 days. And then they were advanced, 12, 24, and 48 grams up until day 14. The normal protein diet was given 1.2 grams of protein per kilogram, and that was consistent the entire time. Then they measured protein breakdown, and that was at day 2 and day 14 by what they call glycine N15 infusion method. I have no idea what that is. I read it, it is confusing. It's some crazy biochemical process that they do to measure protein breakdown. So, the results came out, and there was nothing significantly different in inducing or complicating encephalopathy with the normal protein diet. So the low protein diet did not show a benefit, and neither did the normal protein. It was just consistent. So the one thing that they did show, and that was about inducing or making encephalopathy worse. It did show, however, though, that the protein breakdown was worse for patients who had low protein diets the whole time. So based on this, the conclusion was that it is more metabolically adequate to administer the normal protein diet. The downfall to this study was the sample size. Hospital length of stay is hard, and I think how do you control all that all the time, and for future studies, I mean, that's just really intense. And then the other thing is they're only patients with cirrhosis. So there's a lot of different other complications of liver disease, and these seem to be the ones that we have the most control over. Also, these are the ones, I guess, that we're most worried about, hepatic encephalopathy, so I don't know if that's why they do that, but that seems to be the only group. The next study was George's study, and it was improvement of hepatic encephalopathy with high kcal and high protein diet. So this, once again, was with patients with cirrhosis, but this was now a test group of 153. And this was done in 2005, so it's not that long ago. And they used just a casein, vegetable-based, high-protein, high-calorie diet. This was 30 kilograms, or 30 calories per kilogram, and 1.2 kilograms per protein for 14 days as well. Now, the other thing that this study did was they split it into 4 meals a day and an HS snack. So it was basically 5 meals a day because the meals in the daytime were small, and the goal was to keep protein consistent throughout the whole day. And then they did daily assessments, which is also very interesting. So they did these games like mental status, counting, all these different things. Then they also monitored bowel movements, blood ammonia, and they used what they call the West Haven scale to assess the improvement of mental status. So the results were, out of 153 patients, 122 patients, or 79%, improved their mental response. They decreased their blood ammonia, and so that was really positive. They had also had a subcategory, which was for like a child, like 18 and under, and that was actually not as effective for the children. However, it was more effective for anyone who had severe impairment of mental status previously, or patients that had a little bit more preserved liver function to begin with. So the conclusions from this one was that dietary protein restriction is not required for the improvement of hepatic encephalopathy, and that consistent protein intake throughout the day may contribute to hepatic encephalopathy improvement. Now, my questions with this study were, if they're doing all of these games, like mental stimulating games with these patients every day, don't you think their mental status would get better anyway? Like, for the most part, they're doing retraining and they're working some of those. So that was like kind of an interesting thing that I thought about. And then there's no control group. Everybody was in the study, and there was no group that was not getting these treatments. Let's see what else. And once again, it was, the other thing I was thinking about, they picked the casein and vegetable-based protein. Well, what if they picked like an animal, like all animal source, or all, like they could have done different types of protein, which would have been interesting. And so based on that, here's the third study, and this is from Charlton, and this was done in 2006. And this one was actually more of a review of like 5 different studies that they've done on branched chain amino acid supplements for liver disease, and it was really interesting. It seemed like most of the smaller studies reported improved metabolic profiles and normalized respiratory quotients and improvement of hepatic encephalopathy. However, there were also some studies that showed no benefit. There was no complications, but there were also no benefits. One randomized controlled study, and this was actually impressive, 646 people were in this study, and they through that study determined that branched chain amino acid supplementation is associated with decreased frequency of hepatic failure and complications. However, they had issues with cost, and I guess it tastes horrible, so people do not like it. The palatability are just like huge issues that they had to get over. And I think that may have been some of the problems to the earlier studies, where people were saying they may have been taking it and they weren't, and who knows. Plus, it is very expensive. So that's pretty much what the main research that's out there right now says. The qualms of research we've already talked about a little bit. You know, it's how do you control all these other factors? And unless you're really feeding everyone, like through enteral feeding, like you can't control what they're eating all the time, and measuring everything can be really difficult. So what does the ADA say? Well, this was interesting to me because I went on their nutrition care manual and print out what it says. And it says, at first, adequate energy and protein to meet estimated needs. So if you're just assessing someone, you would use whatever was appropriate. But then